Bismillahirrahmanirrahim. Management of sarcoidosis. Most patients with pulmonary sarcoidosis do not require treatment. As asymptomatic chest X-ray infiltrates are usually just monitored. The most recent British Thoracic Society guidelines were issued in 2008. BTS guidelines for the management of sarcoidosis of 2008 include the following. Because of high rate of spontaneous remission, treatment is not indicated in asymptomatic stage 1 disease. Second, if because of high rates of remission, treatment is not indicated in asymptomatic stage 2 or 3 disease with mildly abnormal lung function and stable disease. Again, the second guideline, because of high rates of remission, treatment is not indicated in asymptomatic stage 2 or 3 disease with mildly abnormal lung function and stable disease. The third guideline, oral corticosteroids are the first line of therapy in patients with progressive disease determined by radiology or on lung function, significant symptoms, or extrapulmonary disease requiring treatment. The fourth guideline, treatment with prednisolone or equivalent in dose of 0.5 mg per kg per day for 4 weeks, then the dose reduced to a maintenance dose which will control symptoms and disease progression and should be used for the period of 6 to 24 months. The fifth guideline, biphosphonates should be used to minimize steroid-induced osteoporosis. Then the sixth guideline, inhaled corticosteroids either as initial treatment or maintenance therapy are not of significant benefit. They may be considered for symptom control as cough in a subgroup of patients. The seventh one, other immunosuppressives or anti-inflammatory treatments only have a limited role but should be considered in patients when corticosteroids are not controlling the disease or side effects are intolerable. At present, methotrexate is the treatment of choice. The last guideline for 2008 of management of sarcoidosis according to BTS guidelines, lung transplantation should be considered in end-stage pulmonary sarcoidosis. Now, what indications for immunosuppressive treatment? Indications for use of immunosuppressive treatment include the following: increasing symptoms, deteriorating pulmonary function tests, and worsening chest X-ray infiltrates. Second indication is cardiac sarcoidosis. Third indication is neurosarcoidosis. The fourth indication is sight-threatening ocular sarcoidosis. The fifth indication is hypercalcemia. The sixth indication is lupus perennial. The seventh indication is splenic, hepatic, or renal sarcoidosis. Now we will speak in details about treatment of sarcoidosis. Starting drug treatment in sarcoidosis. When required, treatment is usually with steroids initially. Good evidence for short to medium term improvement in symptoms, respiratory function, and radiology, but long term benefits less clear. Give high doses, such as 30 mg prednisolone per day, to control active disease. Rarely need more than 40 mg per day. Usually give this high dose for 2 to 3 weeks and then reduce if there has been a response. The maintenance dose of around 5 to 20 mg to control symptoms and to prevent the progression of disease. Leave on this dose for a few months and then slowly reduce steroid dose further. Maintain on low dose of prednisolone 5 to 7.5 mg per day or alternate day for prolonged period of up to 12 months to consolidate resolution before considering a complete withdrawal. Remember bone protection with a biphosphonate. Avoid routine calcium and vitamin D supplementation. Sometimes E point G points with progressive pulmonary sarcoidosis may require longer treatment, as for example, years of low dose prednisolone to prevent relapse. Inhaled steroids are of limited efficacy in sarcoidosis but may be useful if there is cough or bronchial hyperreactivity. Relapses often occur when the treatment is stopped and may require the reintroduction of steroids or the increase of steroid dose. Duration and dose of steroids is dictated by site and response to treatment. If steroid treatment fails or sarcoidosis life threatening, other immunosuppressive regimen may be indicated, e.g., pulsed high dose intravenous methylprednisolone, especially for neurosarcoidosis. In case where prolonged immunosuppression is required, or if steroid side effects cannot be tolerated, other immunosuppressive drugs should be considered. Possibilities include azathioprine and methotrexate. There are limited data for their use in sarcoidosis. Patients who have troublesome symptoms related to sarcoidosis, such as arthralgia, skin disease, fever, sweats, ocular systemic symptoms such as fatigue, may require symptomatic steroid treatment. Lower initial doses, such as 20 mg per day, are likely to be sufficient to gain symptomatic control, and doses can then be reduced. Other drugs used in sarcoidosis. If there is progressive pulmonary sarcoidosis refractory to steroids, we consider use the following: methotrexate, which is given once a week in dose of 10 to 15 mg PO for 6 months trial. Use instead of or in addition to low dose prednisolone. Avoid methotrexate if hepatic or renal heart failure present. Side effects of methotrexate include gastrointestinal upset, stomatitis, pneumonitis, myelosuppression, teratogenic, teratogenic effects reported in methotrexate use. We should monitor the blood count and the mean corpuscular volume and aspartate aminotransferase AST, alanine aminotransferase ALT every 2 weeks for 3 months, then monthly. Don't use for more than 2 years without review. It is useful for chronic sarcoidosis and cutaneous disease to use the methotrexate. Azathioprine. It is used in neurosarcoidosis and stages 2 and 3 pulmonary sarcoidosis with partial or no steroid response. The dose is 100 to 150 mg per day, used instead of or in addition to low dose prednisolone. The side effects of azathioprine is myelosuppression, GI upset, stomatitis, idiosyncratic reaction, fever, rash. It is low oncogenic potential and there is no gonadal toxicity. The monitoring is by doing FBC every 2 weeks for 3 months, then monthly. Thiopurine methyltransferase TPMT testing should be performed prior to commencement. Antimalarial, such as hydroxychloroquine in dose of 200 mg OD or BD for skin, particularly hypercalcemia, and particularly used in hypercalcemia. Steroid sparing, antimalarial or hydroxychloroquine is steroid sparing, can be given with steroids and other immunosuppressants in severe sarcoidosis. Side effects rarely occur, rarely there is ocular toxicity. The other medications include leflunomide, cyclosporin, thalidomide, tumor necrosis factor alpha inhibitors such as etanercept, infliximab, but should be used in conjunction with specialist centers. Last, the prognosis of sarcoidosis. There is no prognostic markers in sarcoidosis apart from the following. Good prognosis in Lovren syndrome has complete resolution in 80% of people and associated with HLA DQB1 star 0201. Poorer prognosis with chronic disease, lupus preunium, nasal mucosa involvement, chronic uveitis, chronic hypercalcemia, nephrocalcinosis, neural involvement, age more than 40, and black race. Prognosis according to chest x-ray appearance is stage 2, 50% of cases recover spontaneously in 2 years. 30 to 40% requires systemic steroids and 10 to 15% require long-term steroids. The stage 3 worst prognosis, only 30% show significant improvement with steroids given or gene expression from mRNA profiling has shown early promise in differentiating progressive from non-progressive disease. The transplant consider if the patient's lung transplantation considered if the patient has end-stage lung disease, rapidly progressive disease despite treatment, or if they are O2 dependent. Sarcoidosis is a rare indication for lung transplant. Granulomata recur in transplanted lung but do not cause higher rates of graft failure.